Well, welcome everyone. I'm super excited about this Tuesday session. So today I'll be discussing with Ravi, who's recently come back from Alaska. So survived the bears, which is great. And then today we have a wonderful case prisoner, Tanzu, and then Simi and Lyra will be helping as well. So Tanzu, would you start out by unmuting and telling us what you've been up to and any fun summer activities?
Sure. Hello, everyone. I'm so excited to be here after so many months of being away from the VMRs. I am a PGY2 now. I just started my year. It had been 1 month of being a senior resident, and I saw this case actually in the last month of my intern year. And it was a very interesting case. So I'm very excited to hear Ravi and AM case discussion on this case. I didn't plan anything fun for this summer because I'll be working, but right now I'm on my elective rotation, so have a lot more time than last year. So I'm hoping to bring many more cases in the coming weeks.
That's awesome. Simi, would you introduce yourself?
Hello, everyone. Thank you for joining. And we had great rapid fires with Dr. Ravi and the MK, and I'm very excited for their discussion today and Tansu's case. Looking forward to the session today.
Lyra, would you say hi as well?
Yeah, hi everyone. My name is Lyra. I'm a very recent medical graduate from Russia. Yeah, very excited for today's session.
So without further ado, let's get started.
All right, so today we have a 40-year-old gentleman who presented with body aches, chills, and headaches for 4 days. And I'll just stop here because I'll give you a lot more information in the HPI.
Okay, awesome. I can just share some quick initial thoughts, and then I'll see what Ravi is thinking, and then we'll go from here. So the first thing I'm thinking out is this sounds like kind of a more systemic, but I'd also say sounds like almost, flu-like illness. And so the important things I'm going to be thinking about here is who is our host. It sounds like a middle-aged male, or as I'm getting closer to 40, young male. And so I'm going to be want to know about the past medical history, the social history, the exposures, because those could all dramatically change my differential in how I'm thinking about this, and also just really trying to figure out with the headaches, are there any alarm symptoms that I need to be worried about to like make me move my center of gravity from maybe a diffuse process that's causing a flu-like illness to something that could localize like in the head, like a meningitis or something like that. So it's a very common presentation, and it could be anything from a benign viral thing to something really serious. And so that's, I think, the fun of medicine is kind of letting it unfold. Ravi, what are you thinking about?
Yeah, MK, I'm really glad to rope you in for this one today and just listen to your wisdom about this case. This is eerily similar to the case you presented for UNC. Just this headache and this generalized constitutional syndrome. Yeah, I kind of don't want to fall into that, what do you call it, the pitfall of just investing too much at this juncture. But yeah, this is like any garden variety sort of a viral illness or infectious illness at this point. I think before we pivot to some diagnosis, I think some data is necessary at this point, like you just laid out wonderfully, all the different things, who is the host, background, story. This kind of rings a bell. I had a farmer once who had all these different pets and animals and cows and drank unpasteurized milk. So it opened the book on all sorts of weird infections, zoonotic infections. So we really do need more history, which Tansu was alluding to initially. But I think we're off to a great start, and great to see you back, Tansu, after a long time, and thanks for bringing this case. Back to you, Tansu.
Thank you so much, Ravi. Okay, so great discussion so far. Exactly like you said, who the host is important. The exposures are very important. So this gentleman's symptoms started, as I said, 4 days ago while he was at work. And throughout the day, gradually he started feeling worse and worse. He came home after work, he checked his temperature, and the highest measured temperature was 103.4, which is 39.6 Celsius. And he took the next day off. He slept all day. And upon waking up, he realized that he had bitemporal headache that was 6 out of 10, pulsatile, and it was associated with photophobia and phonophobia that lasted for hours. And he took Tylenol and ibuprofen several times throughout the day, which brought down the headache, the pain, and the fever. But after the medications wore off, he became febrile again. He denied any history of migraine headaches, but he endorsed that he had a past medical history of tension headaches. And he endorsed that he had a similar headache and a febrile episode 10 years ago when he was hospitalized for amoebiasis and amoebic abscess in the liver and lungs. And at this point in time, he denied any blurry vision, lightheadedness, dizziness, chest pain, shortness of breath, cough, rhinorrhea, nausea, vomiting, or diarrhea, and abdominal pain, as well as urinary symptoms. So the review of systems was otherwise negative. And he endorsed a discomfort in his neck, but not frank stiffness of the neck. And he didn't have any known sick contacts at work or at home. And maybe I will just give you a little bit of a social history here too. He lives with his wife, and he has 3 cats that are vaccinated and shelter adopted. He recently traveled through several US cities across the Northeast, Midwest, and Mountain West. He stayed in a few hotels, and though that trip was for business, and he denied recent freshwater exposure, hiking, or tick bites during his travels. And the only thing that he reported was that there was ongoing mold issues in his building's central air conditioning system, and him and a few other neighbors saw mice in their building. And I will just stop here.
Wow, Anne Marie, we were anticipating something, right? That would help us or would sort of unmask what's going on. So let me kind of dabble initially in superficially in what Tansu has laid out. There's a lot of information here. So just the symptoms of headache, right? So we were trying to latch onto what really will help us gain traction here. And I guess the headache, but the headache could be a upstream reflection of something internally, which is probably propagated from an external condition brought on by maybe this rat or cat or any one of these pets or animals that are surrounding him. Although he's also been on this travel history with mold exposure. So we have multiple different conditions that could actually cause an infection. So we're in the domain of infection. And headache, it's, at this juncture, we may have to start thinking about something that could be along the lines of meningitis. Not encephalitis at this point. Encephalitis, that is a inflammation of the brain itself. So I would anticipate altered mental status. I would anticipate focal neurological deficits. With meningitis, it comes on more insidiously, headache and so on. In the exam, how much weight would like nuchal rigidity, Bernick, Krasinski give, jolt, reflex? Not too much, actually. If we looked at previous VMRs where the sensitivity specificity wasn't that great, so you can still have no nuchal rigidity, back pain, and so on, and still have meningitis. So at this point, I think meningitis is key. Could it be bacterial? Could it be viral? Could it be parasitic? Could it be with the mold and #mold? And could it be fungal? Any one of those could be fair game. But then again, you laid out a really important point in the beginning. Who is this patient? So getting an HIV test is very important. Seeing if the patient's immunocompromised, that also swings open the door to various opportunistic infections. And I think I would also put in there malignancy. So I think key here is, should we start off with the headache? Should we look at an LP or the other systemic features in the exam, maybe also in the labs? There was something about the patient has been traveling all over Midwest and so on. So there could be a possibility of tick-borne disease as well. But I think there's a few signals that can be emitted maybe from the labs. Dermatological exams sometimes can help if it's early on, but we'll see. We'll see. I mean, I kind of dabbled all over the place with this. Anything come to mind, or is there anything that you can really hook on to help us gain direction in this case?
Yeah, so I think there's a few things. I think one of my weaknesses is sometimes latching so much onto something in the social history that could be signal or could be noise. And so here I really try to keep an open mind, like acknowledging these things and thinking about these things, but also acknowledging, like, I think there's a little like mold in my house right now because of all the rain. And it's a very common thing. And humans like live commensally, like with mold exposures. And most of the time, it doesn't cause symptoms except, if in the right host, if you're immunocompromised or if you like have a hypersensitivity reaction. So I want to like kind of stay really broad still, but also kind of acknowledge some of these things could be signal or could be noise, and kind of think accordingly to that. So I definitely agree, ensuring that we know the immune status. I'm not getting a lot of other signal to like really make me think that this is immunocompromised host, but it's always good to look at that. And then also kind of thinking of all your basic stuff, like all your viral stuff, as you mentioned, tick-borne, acknowledging that like up to 50% of people don't see the tick bites or like notice the tick bites because they can be painless and things like that. Tick-borne illness is other sort of viral meningitis. And then also thinking like, could the mice be significant? Perhaps, like, thinking about leptospirosis, thinking about like rat bite fever, although it doesn't sound like there have been exposures related to that, thinking about lymphocytic choriomeningitis and everything, but also not getting so wrapped up in that you like kind of lose the obvious base rate things that could be going on. And then I'm always thinking about like if there's kind of changes in the AC and kind of like this diffuse syndrome, thinking about Legionella too. Here, I'm definitely going to want to be doing more evaluation for meningitis because I'm worried about that. Remembering that a lot of the physical exam maneuvers like Koenig and Brudzinski's sign are very late manifestation and have low sensitivity. So thinking about doing something like the Jolt test as well, and having a really low threshold in this case to go ahead and get the LP, because I think we're definitely getting more signal. A headache can be very non-specific, but like with the photophobia and phonophobia and someone who doesn't have a history of that, I'm definitely not wanting to miss a meningitis.
Okay, back to you, Tansu.
All right, excellent points. So I'll provide some past medical history and give the vitals and walk us through the physical exam. In the past medical history, patient had pre-diabetes with an A1C of 5.8. That was 3 months ago. As I mentioned in the HPI, he had a liver and lung abscess because of entamoeba histolytica 10 years ago. And this was in the setting of a trip to India. He also had ADHD, anxiety, insomnia, and mild intermittent asthma, also allergic rhinitis. And the medications that he took were texofenadine daily for his allergic rhinitis and propranolol 10 milligrams PRN for anxiety, lisdexamfetamine for his ADHD, and trazodone for his insomnia. Family history was non-contributory. In the social history, he had an office job, worked as a software engineer, and I mentioned a little bit of the social history in the HPI as well, lived with his wife and cats. In the health-related behaviors, he smoked electronic cigarettes and marijuana for the past 10 years daily, and he drank 3 to 4 beers a week. And his allergies were dog and cat dander and pollen. And in his initial physical exam, his vitals were significant for a temperature of 39.3 Celsius. That's about 103.4 Fahrenheit. His blood pressure was 110s, 113s over 70s. And his heart rate was a little fast. He was a little tachy, 95 to 112. And he was saturating 96% on room air. On the physical exam, he seemed to be in acute distress, actually. He was curled up in bed and pulled up his hoodie over his face, clearly irritated by the light in the room. So his pupils were equal, reactive to light, and his extraocular muscle movements were intact. Oropharynx was clear, neck was supple, and I didn't palpate any lymphadenopathy. And there was reported neck stiffness, but on physical exam, there was actually, I couldn't elicit any neck stiffness. Kernick and Brudzinski signs were negative. On the cardiovascular exam, he was tachycardic, S1, S2 were present, and I did not hear any murmurs, rubs, or gallops. On the lung exam, I didn't hear any wheezes, crackles, or rhonchi. He wasn't using his accessory muscles and no increased work of breathing. On the abdominal exam, his abdomen was soft, non-tender, non-distended. His bowel sounds were normal. And his neurological exam was also normal. He was ANO times 3. His skin was warm. I didn't appreciate any edema or rashes, and he did not have any jaundice either. But there was some tenderness on palpation in bilateral calves, but there was no swelling or erythema otherwise, and the range of motion was normal, and he had normal strength throughout. And I'll just stop here. And then maybe you can discuss, then I can give you more objective data with the labs.
Awesome. I'll start. So just looking at the vital signs, like this patient is febrile. I do think it's interesting because they are tachycardic, but perhaps not as tachycardic as I would anticipate with that high of a fever. I haven't done the exact calculations, but that's just an important thing to think about if you're thinking about maybe an intracellular pathogen. Usually, I think for every degree, your heart rate goes up by about 8. And I'm very worried about this patient, even though they have, a decent blood pressure and a normal oxygen saturation, just like a 40-year-old, like otherwise healthy, who's traveling like the world is now like in distress, curled up in bed. That's really, really concerning signs for me. And then even though, like, as we talked about previously, even though the Kernig and Brzezinski sign are negative, those just don't have great sensitivity. And so I'm still really worried about like a meningitis. I don't see obvious signs that makes me think of an encephalitis because it seems like this patient is still, able to like answer questions and doesn't have like profound changes in the sensorium. And so, yeah, I'm going to be thinking about that. I was wondering if there'd be other clues, like lymphadenopathy could have been a really helpful clue, or like lesions in the mouth, or like a rash on the palms or soles, or another rash. Could have like been a really helpful clue to point us in a specific direction. But right here, all we have is like tenderness in the calves, which I think could be a helpful clue. I'm curious if the CK will be elevated or not, because sometimes patients get myalgias with like viral or even certain bacterial infections that won't have elevated CK, but sometimes it's part of a whole kind of inflammatory syndrome, and you will see an elevated CK. And so I'm very kind of curious what the further labs will show, like if we're going to see hyponatremia, because I think that could be a big clue. If we're what the differential on the CBC is going to show, because that could be a big clue. If there's going to be creatinine elevation, I'm kind of looking for something to kind of help me center in on possible clues right now. Ravi, what are you thinking about looking at this data?
I'm just amazed at how remarkably you're using the power of anticipation. I think one of the things that I reflect on with experience is early on with a complaint, you start generating various hypotheses, right? To prove the hypotheses, you anticipate finding lab abnormalities like you've laid out. Or on the exam, you will specifically look for maybe petechiae or rash to then support your hypothesis of maybe a tick-borne illness or something like that. So if you don't think of it, you won't look for it, you won't diagnose it in this case, and then you won't be able to treat it. So this is really powerful for a lot of learners. I think early on trying to think of conditions and not even a specific diagnosis, but maybe a group of diagnosis and relate certain features like early on we thought about meningitis, so maybe looking at nuchal rigidity and so on, but they're not very powerful. So then we have to shift back and say, okay, what else can help us to make that diagnosis? And maybe it will be getting an intervention like a lumbar puncture to see what is in the CSF. So I think what you laid out there is really helpful in this case. I definitely do take your advice, because when I went to Alaska, no bears attacked me because I didn't put any salmon in my pockets. Remember, remember that? But I did carry some bear spray, but I got to see, I think I sent you some pictures of some bears that I encountered. But transitioning back to the case, I think there's not enough, I guess, to really say what kind of condition do we have here. I think the labs, like you mentioned, the labs very important. I want to go back early also. Tansu had mentioned about these abscesses that this patient had. Is she trying to lay out some breadcrumbs, a trail of breadcrumbs that we have not picked up on? We were trying to think about this disseminated amoebiasis in the liver and the lung. So this patient has had this condition before. Could this be I guess, long-standing complication from there? I kind of have to think through. I've not encountered that before. So I would kind of put a pin in that and just kind of track it along with all this other data. I'm eagerly anticipating the labs to see if there's any signal there. Like you had mentioned, all these wonderful abnormalities, could thrombocytopenia or hypernatremia, so on, liver enzymes and so on. These could give us a signal for condition. There's certain pattern recognition which we could utilize there to make maybe a diagnosis at this point. This tenderness on palpation to the bilateral calves is very easy. Then a lot of times I see early learners may just get a venous duplex. You see, oh, could there be a DVT there? But I think this could be just part of this complex infection, myalgia, back pain, leg pain, and so on. Although sometimes it could be an inflection point to a certain condition. Okay, I had somebody present a case yesterday where there was this kind of pain, generalized pain, infection, and the leg pain actually was an abscess. So I thought it was just a myalgia, back pain, leg pain, myalgias, but it was actually screaming out an abscess in the leg. So you do have to also anticipate that. So anticipation is very powerful in kind of solving a case like this. But at this point, I think the labs might be very helpful. Yeah. At this juncture, is this patient very sick? The vital signs are very key. So we always do teach our residents to try and identify a sick patient, if the patient is sick or not. Right now, we don't have the diagnosis, but is the patient sick enough? We need to transition them to a higher level of care, do some life-saving interventions. At this point, patient is hemodynamically stable. This fever is worrisome, heart rate's fine, and there's no respiratory compromises at this point. So it gives us some time to try and work out what's going on with this patient. If we do go for an LP, a commonly tested feature is, do we do in the sequence of events, we need to get an LP, of course. but there are certain conditions where you need to get a CT, but even before that, we need to give antibiotics. So if in Tansu's case, empiric antibiotics, if they were given, that's usually a standard of care. And then you de-escalate the antibiotics as you receive data, which will be the CSF analysis. So at this point, I don't see, so the mnemonic we use is POUND, I think, papilledema, focal neurological deficits, space or history of space occupying lesion within the brain, immunocompromised status. These kind of features would prompt you to do a CT before LP. So at this point, we don't have anything here. Yeah, nothing here to really scream out. Pre-diabetes mellitus could be assumed to be a immunocompromised state or bordering on an immunocompromised state. Looking also at the medications, could this be something, a complication due to the medications? Any of the medications could be immunocompromising. I don't think so at this point. But I'll switch it back to Tansu for some laboratory data to see if we can gain some traction with this case.
All right. So by the time we saw this patient and when the decision to admit the patient was made, he triggered SIRS criteria in the ED by being febrile and tachycardic. So he definitely received antibiotics even before we saw him, and already 2 sets of blood cultures were collected. He received ceftriaxone, azithromycin, and vancomycin, as well as Tylenol and some fluids too. So the first set of labs that were already obtained by the ED were a BBG that showed a pH of 7.43, PCO2 of 37, bicarb of 25, and lactate of 0.8. And we also have a CBC with a WBC of 7.4, which was neutrophilic predominant. Hemoglobin was 11.8 with an MCV of 92.5. Platelets were 90,000, and the baseline from 3 months ago was 252,000. And on the chemistry, his sodium was 136, potassium 3.9, creatinine 1.73 from a baseline of 0.9 3 months prior again. And his GFR was 51, BUN of 15, calcium 8.5, phosphorus of 3.4, magnesium of 2, and otherwise rest of the BMP was normal. We also got LFTs. On the LFTs, he had a normal bilirubin, both total and direct. ALK-Phos, AST, and ALT were all slightly elevated. ALK-Phos was 145, AST was 93, ALT was 73, and total protein was 5.6 and albumin of 3.1. We also had an LDH, which was 348. ED/RD obtained a viral swab too for COVID, influenza, and RSV, and that was negative. And we already have a urinalysis as well that showed moderate blood, but urine microscopy did not show any RBCs. And CPK was also elevated. It was 817, and HIV was negative. We had an EKG that was normal sinus rhythm, a chest X-ray that did not show any acute cardiopulmonary process. We also had a CT head, which did not show any intracranial hemorrhage, acute lobar infarction, or any intracranial mass. And ED also obtained CT of the abdomen and pelvis because the patient triggered SIRS. I think that was their reasoning. And the CT of the abdomen and pelvis showed non-specific enlarged portocaval lymph nodes with no visualized acute intra-abdominal or pelvic pathology, but the lower lobes of the lungs were captured in the CT of the abdomen and pelvis, and that showed bilateral GGOs. And they also recommended to get a dedicated imaging of the chest for further evaluation. And I will just stop here.
A wonderfully presented case, very complex, lots of data here, and strategically played out to help us understand what's going on with this patient. But I'll sort of kick it off Anne Marie, the big thing here with the CBC, I mean, yes, this patient is sick and not ICU level sick, but is sick enough. But the CBC, the white count is not terribly high. And we always base white count elevation with, you could say, degree of infection. High white count would have our antennas up. At this point, normal white count doesn't eliminate the matter of infection. But here what we have is a burgeoning neutrophilic count. So maybe tomorrow it's not unremarkable that the next day we've seen many times patients come with normal white count, and the next day you see it jump up and unmask the patient's true underlying inflammation secondary to an infection. So I wouldn't discount infection at this point with the white count of 7.4, but the neutrophilic count is burgeoning, and that does indicate likely a bacterial infection / could be other infections as well, especially in early viral infections. It could be neutrophils, which will transition to lymphocytes. The platelets, we were thinking about platelets. We didn't see petechiae. We were kind of excited about patient traveling all over the US, maybe tick-borne disease. And with a lot of tick-borne diseases, you can get thrombocytopenia. There could be splenomegaly in the exam as well, which we didn't see. But here, the platelet count, I'm going to sort of think about that. Why would the platelet count decrease? Especially we have a baseline. Thank you, Tom. So the baseline helps because this is a drop. So if we simplify the matter of thrombocytopenia, either it's a bone marrow issue, it's a destruction, or a sequestration. I don't think at this point we have any feature of sequestration. We don't have splenomegaly, so we do have to think about maybe inflammation through pro-cytokine inflammatory mediators causing a decrease in the production in the bone marrow. I don't see any signal for destruction or consumption. So when you have excessive bleeding, you tend to make a lot of clots, and that can cause a consumption as well, sometimes a consumptive coagulopathy. DIC, those patients are terribly sick. I mean, TTP, HUS, and so on. We don't have any kidney injury here. So I don't think we're in that terribly sick domain. But I think this is just some part of this complex, or this feature of this infection that we have here. If we start thinking about infections, we were thinking about with this lung now being involved, which is I'll let you comment on that. But Legionella, we were thinking about, there's a certain pattern associated with Legionella, and I think a very strong pattern that is associated with that is hyponatremia, which we're not seeing here. So that would maybe have our antennas up for Legionella pneumonia, and with these lung features that could particularly happen. And those patients are usually the patients that I've had with Legionella pneumonia are very, very sick as well. And you can also get a rhabdomyolysis as well with the patient. Oh, sorry, I did see the creatinine. For some reason, I didn't glance, so I glanced over it, but it is abnormal in this case. But again, I doubt at this point we're dealing with anything with a hemolytic process. Patient doesn't have jaundice at this point. The bilirubin is normal. But I'll stop there. So yeah, the platelets are interesting. Could it be also, I mean, the patient has sepsis. Sepsis complex does have thrombocytopenia associated with it. Is any particular infection that comes to mind with thrombocytopenia? You mentioned like the intracellular pathogens like anaplasmosis or ehrlichiosis have that sort of complex. And then the tick-borne illnesses can also, like Rocky Mountain spotted fever, can also manifest like that. Anything else comes to mind, Anne Marie?
Didn't unmute, rookie mistake. So I think here, like with the thrombocytopenia, so many infections can cause it, and it could certainly be a sign of like a tick-borne illness or another atypical illness, or even like certain viruses and things like that. But sepsis itself does, and a lot of times when the body is under stress because of the half-life of the platelets being 7 to 10 days, it's the first thing that you kind of see the body is telling you it's stressed and it's prioritizing resources away from the bone marrow, and that can be the first sign. So I definitely want to like track it, because it could be it's 90 and then tomorrow it's like, 70 and then 50, or it could just be kind of a sign of everything else going on right now. And so, yeah, I'm going to be watching it. I'm going to be like looking at a smear, because the smear could give us like valuable information. But I'm probably not going to be like diagnosed as long as I don't see like signs concerning for like TTP or like an emergency. I would definitely make sure that we have our coags, but I'm probably not going to be investing too much energy at the time. I think instead I'd be trying to like figure out like where the fingerprint is. I think the ground glass opacities in the lower lung is so interesting, because sometimes these atypical lung syndromes can be really sneaky, and they can be in the lungs, but like in someone with young, healthy lungs, you don't always see like the signs that they're in the lungs. Like you don't always see hypoxemia or other signs. And so it can like make it harder to find its signature. Ground glass opacities are more diffuse, kind of these hazy opacities that you can see in the lungs. And a lot of times they represent something like some sort of interstitial process. And so we commonly see that like in patients with heart failure, you can get that, or even like ILD. But in this case, I'm really thinking about like some sort of atypical process, which a lot of times is viral illnesses. Like COVID was notorious of causing this, like atypical things like mycoplasma, Legionella, and things like that. And so I definitely want to get a better sense of getting dedicated imaging of the lungs itself, to better understand kind of where the signature was. And then I would definitely be getting a full respiratory pathogen panel, thinking about also dedicated mycoplasma, Legionella urinary antigen, just to kind of start out. But then I'm still thinking about, the LP and everything, and, trying to say like, is this headache the center of gravity, or is this part of a more systemic process that we're missing? Any other thoughts before we get more information?
Not really. I think what's really great is just listening to you. You're because we're not really centered with our or we haven't proven our hypothesis that we generated early. We're in the refining. We're still refining our hypothesis here. So how do we do that? By getting more data. So we got a lot of data. A lot of it excludes maybe quite a few diagnoses, but we got more complex data now, and we have to then determine which way to go. And I think a very powerful point you made was the lungs. We got a little portion of the lungs with our CAT scan. Now we got to get the full picture. And so doing imaging there is very, very important. So even before, say for a case like this, you're going to get a consult. Maybe you're like, oh, I see ground glass opacities. Let me get a pulmonary consult. You need to get that CT, so that way the pulmonologist can take a look at the whole the landscape of the lung rather than just the bottom sections there. What's interesting with the GGOs and all of this, the patient's doesn't really have terrible respiratory symptoms, right? Earlier on, there was no signal of dyspnea, although the pulse ox is 96% of room air. However, the patient has this long-standing inhalation history, right? So there's electronic cigarettes, marijuana. These can, for 10 years, I think it can have a certain bearing on the lung as well. So GGOs, though, shouldn't be ramification of long-standing vaping and so on. And usually the patients that come with the inflammatory sequelae of vaping and so on are terribly ill, and they're terribly hypoxic and having all these respiratory symptoms. So I don't know if that has any bearing on this case, but definitely we do have to include it in trying to figure out what's going on with the case. So yeah, a CT of the lungs definitely is necessary.
Yeah. I love your part about EVALI, because I honestly had so much data. I even like, it's really easy in these cases to forget a data point. So I saw something in the chat about the moderate blood. I don't think we explicitly mentioned it, but a lot of times when you see blood, but you do not see RBCs, that is a sign of some sort of breakdown, like a myoglobin product. So here we think it's probably secondary to the elevated CK. And then if it was just AST in the liver enzymes, that can also be secondary to elevated CK as well, because AST to ALT in the muscles are in about a 4-to-1 ratio. Here we also see ALT and alk phos, which could be bone, it could be liver. So I think there's probably some sort of signal in the liver as well, is my guess. But depending on the time course, it's a little unclear. But I'm sorry that we skipped over that. There's just so much data here. And then the kidney injury, I think, will be interesting, the tincture of time, because I would not be surprised if we gave fluids and it was better the next day. But if it keeps climbing or elevated, then that actually could be, signal rather than just like the noise of a febrile illness getting a prerenal AKI or something like that.
Oh, thank you for covering those. I completely glanced over that as well. But you're right. There's a lot of data here. In real life, you get these data points piecemeal, so you get to mull over them. But we're getting everything as a bolus of data here. But yeah, the liver. I mean, great point about the rhabdo. This is the CP. We're not even in full rhabdomyolysis territory. Usually CPK is probably 10,000 or above. But here 817, and great point about the UA with the moderate blood, but no RBCs there. So major teaching point. Thanks, Anne Marie. Back to you, Tansu.
Great discussion as always. So we were still at the point of defining the problem ourselves too. And as Andrew asked in the chat, so some of the other hemolysis markers, his haptoglobin was actually normal. It was 260. And on the peripheral blood smear, we did not see any schistocytes. And as you also wanted to obtain, we got a dedicated chest imaging, which showed on the CT of the chest, bilateral diffuse airspace opacities with some peribronchial distribution. And given the rapid onset of symptoms, as well as the CT findings, radiologists were favoring a atypical pneumonia process or viral pneumonia process. And we consulted ID at this point too and got their input. And ID recommended also sending a rapid respiratory pathogen panel, the broad panel. At this point, we have already sent the Legionella urine antigen, MRSA smear of the PCRs, of the NAIRS, quantiferon release assay, hepatitis panel, tick-borne serologies for Lyme, Anaplasma, Ehrlichia, Rocky Mountain spotted fever, like Ravi mentioned, and serologies for zoonotic diseases too, like Leptospira, Bartonella, Q fever, as well as atypical pneumonias. I mentioned Legionella, and Mycoplasma and Chlamydophilia also included in the respiratory pathogen panel. We also sent antibodies for urine histoantigen, and coccidioides antibody, which reflects to its titer, and parasite smear of the blood, as well as CMV IgM as an IgG and EBV antibody. And then we also changed the patient's antibiotics from, so ID recommended that we stop the ceftriaxone and escalate to cefepime, and stop azithromycin and switch to doxycycline to cover any doxy deficient state. So we followed their recommendations, and then we started waiting for the results of the serologies. And during this time, patient showed improvement and actually got discharged before the test results came back. And he was then followed up in the ID clinic as outpatient. And during that time, the serology results came back. But before I reveal the final diagnosis, maybe I can pass the mic to you and get your final thoughts.
What do you think, Anne Marie?
Oh gosh, yeah, it's hard. It's funny because like it was going through my mind. I was like, is this like, it feels like, are we on the right atypical coverage? Because normally azithromycin is great atypical coverage. It's good for mycoplasma. It's good for Legionella. But like some of the tick-borne illnesses and things like that, you really want to like consider, are we in a doxycycline deficient state? I do not know if I feel that like I really have enough data to like feel confident about the diagnosis, because I think this could like legitimately be a lot of different things. Tanzu, now remind me, where do you currently practice medicine?
In New York City.
Okay, in New York City. So, but has also, traveled. So I could see this, being like a tick-borne. It doesn't have a rash. Normally Rocky Mountain spotted fever has a rash, but you can get occasionally like rashless, Rocky Mountain, and then you can get other like rickettsial illnesses, especially that can be like transmitted by mice, although, like, or anaplasmus or ehrlichiosis. We don't see like the signs of a, secondary phase of leptospirosis, kind of after the prodrome. So, I think this, like, honestly, like, I'm not sure. I think this could be a lot of different things. I would be like curious to, and I don't know how quickly, usually in my lab, the Legionella urinary antigen comes back like super quickly, but I don't know if that's like the case there. So, I'd say I'm not quite sure. But I think sometimes if you can just define it as like a doxycycline deficient state, and kind of say like what coverage do we think we're missing, and then I think like could it be leptospirosis? Maybe. Could it be something else? Maybe. But sometimes just having those broad categories can be helpful. Ravi, what are you thinking?
Yeah, I'm right there with you. I think during our early hypothesis generation, just this social history was very powerful, I think, just trying to figure out where could the answer lie in regards to infection. Of course, infection was established early on. Now trying to verify that, I think sometimes it's one of those conditions, you have a suspicion and you just start the treatment and not wait till you get the answer. So being in a doxy deficient state, and especially with this the mouse and so on. We were talking about lepto, Legionella, and so on. But tick-borne illnesses, even though it says no water exposure or tick bites, but like you said, yeah, these ticks, especially the nymphs, they're so small that it's very hard to see with the eye. So even when I go out gardening, I come back and I have the kids shine a light on me just to see if there's ticks, because tick-borne disease is just rampant across the East Coast, New York City, Central Park, and so on. So the patient doesn't even have to travel anywhere. Central Park's rife with ticks nowadays as well. And so, yeah, starting doxycycline, patients getting better. Sometimes this is the way you diagnose the condition, by treatment response to therapy. Sometimes, like other conditions, we have the other conditions where you don't have the diagnosis, but you have a very powerful pretest probability of, say, GCA, and you start steroids, and there is a positive response to therapy. So in this case, giving doxycycline, patient gets better. This could actually yield you or push you into the area, which will be tick-borne disease, as a possibility of this condition here. And we also, we were kind of I got excited about this thrombocytopenia, and it does have a strong association. Lepto, less likely, the hyponatremia is not there. The hypokalemia is not there. The bilirubin usually is out of proportion to
Yeah.
the AST/ALT. It's not there.
Ravi,
So
what are your thoughts thinking about leptospirosis? Because I think we often talk about it in clinical reasoning when we're in the second phase or in the immune phase, where maybe you see some more of those symptoms. What are your thoughts about maybe this being like the first phase, the acute leptospiremic phase of leptospirosis, rather than the immune phase?
good point. I didn't even think about that. But yeah, we always have to think about patients coming in and they're on this journey of their disease, right? So usually our illness scripts will reflect on the late phase or middle phase of the condition. Early phase, like you just highlighted, I've not seen that happen. And that's where a lot of these cases can be missed. So you're right. What if this is early in the process. So you come in tomorrow on rounds and the patient is yellow like a light bulb, and now you have jaundice. So that's a very powerful statement. I think you're right there. So we can't completely eliminate leptospirosis at this point. So we have to do the diagnostic workup for at least leptospirosis. But the doxy here pretty much is a champion, I think, and will point towards one of these conditions, hopefully.
Yeah, I'm always hesitant to to like say I think it's a very rare disease because I think just like base rate wise and most of the time it isn't. I do think it could tick the boxes for early phase. So like kind of the 5 to 7 day of spirosis, but also acknowledging that that's a very rare diagnosis and there's other things that it could be. But it is a reminder that kind of there's 2 phases of it. So I don't know. I'm excited to hear more.
Back to you, Tansu.
All right. So the serologies all came back negative except for 2 things. And Mycoplasma IgG and Leptospira IgM was positive. And we got another sample during the ID outpatient visit to follow up the Leptospira IgM and to confirm that it was truly positive. And in the second set of workup in the blood sample, it also came back positive. So we confirmed that Leptospira IgM was positive, and we concluded that that was a case of leptospirosis. In the earlier phases, likely leptospiremic phase, with the ground glass opacities in the lungs, but the fingerprint being in other organs, actually very systemically in the liver, in the kidneys. So we thought this was a case of leptospirosis.
Oh, wow. Ann Marie, superior skills earlier on. So kudos to you for still not eliminating. I was ready to chuck out leptospirosis, but yeah, early. I've never seen early. I've seen, what we have a lot here in Baltimore is rats. I know I see so many videos of rats in New York. So there's a scourge of rats. The latest thing I heard about is may prevent or hunting rats or things like that, because it's just they're just running rampant all over New York City. So yeah, mice, rats, that definitely was high on our radar screens earlier on. So great job in bringing me back on board the leptospirosis train. Great case, Tatsu. Really enjoyed that. What a roller coaster. That was so great and expertly presented. Any reflections, Ann Marie?
I think this was an amazing case, and kudos, Tansu, to your team for having a high index of suspicion and probably saving this patient's life, because it would have been so easy to like miss this or not think about that, and could have presented now like with severe jaundice and renal failure and like Wheels disease and all that stuff. So just like amazing kudos to your team. I think that this case for me was kind of an exercise in what signal and noise and like what to invest cognitive energy in. And it's a hard, question. And I think it's just something that like I just value this time, because really getting those continued like reps to say like what is signal and what's noise and what do I need to maybe consider, but like kind of after I've rolled out the more common things.
Oh, Todd, so there's a question in the chat. I think we have a few minutes before we go to teaching points. Something about was you did give a cephalosporin, right, with this patient?
Yes.
I think ceftriaxone was given, which should actually work for lepto. So do you know in this case why there was no response to the ceftriaxone and doxy?
There was actually response to both
There was,
ceftriaxone
okay.
and oxy. Yes, patient recovered to his baseline health within 2 weeks of treatment.
Got it. Okay. Let's move it over to Sime for teaching points. Thank you, Sime, for taking on teaching points.
Thank you, Tansu, for bringing such an interesting case, and I love the discussion. And after so much wonderful teaching, I don't have much to add, so I'll just keep my teaching points very brief. So we had a patient who presented with body aches, chills, and headache, and we were thinking about underlying systemic process, and then we were thinking that maybe the patient has bilateral headache and photophobia, whether it is a separate process or just a manifestation of something systemic. And we discussed that even when patients have normal WBCs but elevated neutrophils, infection is always worth considering. And with the diffuse ground glass opacities, we were thinking about atypical organisms like Mycoplasma, Legionella, Leptospirosis, Tularemia. And one important poll that AMK mentioned was that when we have we have blood in urine, but not RBCs, rhabdomyolysis is something worth considering. And final diagnosis of leptospirosis was made, and I loved the discussion and the session.
Awesome. Well, thank you so much, everyone. It has been so fun as always. And thank you so much for the chat, for being on fire as always. We will see you soon.
Take care. Bye.